Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you for joining us for Evolving Strategies in Psoriasis and Psoriatic Arthritis, a clinical guide for optimized care. During this segment, we will be discussing early diagnosis and screening of psoriatic arthritis and managing comorbidities of both psoriasis and psoriatic arthritis. I'm Alice Gottlieb. I'm both a dermatologist and a rheumatologist and clinical professor at the Icahn School of Medicine at Mount Sinai. And I'm joined by my colleagues, Dr. Philip Meese and Dr. Mark Lebwell. So the title of my presentation is Inflammatory Arthritis for the Dermatologist, Screening and Diagnosing Psoriatic Arthritis for the Dermatologist. And your patient should be saying, my dermatologist, my hero. So I'm thankful to the pharmaceutical industry for changing how patients are treated with both diseases. And as I pointed out in a previous segment, my own mother of blessed memory was a beneficiary of research that led to treatment that improved her psoriasis and psoriatic arthritis greatly. So let's talk about screening for psoriatic arthritis. This is the most important slide I'm showing of my segment. Psoriatic arthritis is the most common comorbidity of psoriasis. In general, it's not difficult to diagnose. And so what if we refer a rheumatoid arthritis patient, a fibromyalgia patient, an osteoarthritis patient to the rheumatologist? They need rheumatologists too. And the reason why we care is psoriatic arthritis is potentially disabling. And it's a shame that psoriatic arthritis frequently goes undiagnosed, up to 41% of folks, and you will see that the publication has a first author, Philip Meese, in it. And we have a long warning sign of that who's at risk for psoriatic arthritis. It's the patient with psoriasis, and it can precede arthritis by an average of 10 to 12 years. So who's the first person who can detect psoriatic arthritis? It's a dermatologist, and we should not be putting this detection onto our primary colleagues. It is our responsibility. And I will give an analogy. If somebody comes in the office with a malar rash, is there any chance that that patient is not leaving without an ANA or a urinalysis? So that it's just like lupus. You need to deal with the comorbidities of the disease. And why does it matter that dermatologists detect psoriatic arthritis early? Because we now have multiple TNF blockers, multiple IL-17 blockers, and a JAK inhibitor that not only control signs and symptoms, but inhibit radiographic progression. And there's even a study with an IL-23 blocker that hopefully will read out soon to see if there is possibility that they will too. So dermatologists can prevent disability by initiating treatment early on. And as I've said in the previous segments, I don't know how a dermatologist can treat psoriasis if they don't know if the patient also has psoriatic arthritis. And I will show you that patients with mild skin disease can have psoriatic arthritis. So that the presence of psoriatic arthritis is independent of presenting psoriasis severity. Yes, it's true that if you have more severe skin disease, you're more likely to have psoriatic arthritis, but you can have terrible psoriatic arthritis and very little skin involvement. Ask every patient at every visit. And here's a paper, primary authored by our very own Philip Meese, which proves that dermatologists don't do a good job diagnosing psoriatic arthritis. In his paper, 41% of those diagnosed with psoriatic arthritis by a rheumatologist were missed by their dermatologist. And this is a famous study that shows that the more the delay in diagnosis, the more disability and destruction one has. Look, it's 11-fold risk of arthritis mutilans with a greater than 6 months delayed diagnosis, a 4 to 5-fold risk of permanent X-ray changes with a delayed diagnosis, and so on. And this is a study that showed that even in mild psoriasis, that almost 30% of patients have psoriatic arthritis. And obviously, if they have severe psoriatic arthritis, this goes up to 50%. Here are the risk factors for psoriatic arthritis. The most important one is a history one. It is a first-degree relative with psoriatic arthritis, which increased the risk by about 30-fold. Other risk factors include scalp psoriasis, inverse psoriasis, nail psoriasis, severe psoriasis, and obesity. We do not have a serum biomarker that can help us with diagnosis. You've heard about the domains from the other speakers. To remind you, they are peripheral arthritis, axial disease, enthesitis, dactylitis, skin and nails. Early psoriatic arthritis does not often present to the dermatologist with a big swollen tender joint. It often presents with enthesitis. I've showed you in these statues what the Achilles tendon is, and that is the most specific joint. And it also can, patients will also say, if you ask them, that they've been treated for plantar fasciitis. Another common site, which I can show you here, is the lateral epicondyle of the elbow. Enthesitis occurs in about 35% of patients. And there was a study that looked at a prospective cohort of psoriasis patients without any musculoskeletal complaints who underwent ultrasound assessment of structural enthesial lesions. There were 114 patients with a mean follow-up of about 18 months. And having structural enthesial lesions was associated with an increased risk of developing psoriatic arthritis in psoriasis patients, with a hazard ratio of 5.1. And I've been involved with trying to teach dermatologists how to use ultrasound units to be able to help in this case. Let's talk about screening for psoriatic arthritis. First of all, we know that there is increased screening compared to when etanercept was FDA approved for psoriatic arthritis, but we still have a long way to go for dermatologists to take responsibility for this. If they want to do a physical exam and history easy algorithm, this is from Joe Marola and his colleagues, it's as easy as PsA. Ask patient about pain in the joints. Ask about prolonged stiffness on immobility, whether it's arising from bed or from a recording session such as this one, and look for swelling and sausage digiting of the fingers and toes. In terms of axial disease, especially in younger people, if they have back pain or alternating buttock pain that wakes them up at night and is associated with stiffness, it suggests an inflammatory cause. I suggest that people download the Grappa app. It's free. And the PEST, which is on there, shows the PsO12. The PEST is a 5-question questionnaire given to patients, and if they answer 3 or more positive, there's a good chance they could have psoriatic arthritis. If they have either a diagnosis of psoriatic arthritis to begin with, or they answer positive on the PEST, they should be handed the PsO12, which is a 12-question symptoms and impact questionnaire. The app calculates the score automatically. It's available in any gizmo you can think of, and it's translated into multiple languages. And at IDIOM, the International Dermatology Outcome Measures Group, we developed an algorithm that is patient-facing, meaning either the patient does it in the waiting room, on their app at home, a patient portal. And what happens is that a patient with a diagnosis of psoriasis can be one of 2 patients. They can be one where they already have a rheumatology diagnosis of psoriatic arthritis, or if they don't have that, they're handed the screening tool for PsA, the PEST. Those patients who either have a known diagnosis of psoriatic arthritis or answer positively on the PEST are given the PsO12. In green, you can see that if the score is less than or equal to 4, they have an acceptable symptom state and one can continue treatment. However, if their PsO score is greater than 4, we need to modify therapy and certainly get help managing. So here we have something where the doctor has done no work to date. The patient has done all this, but you can actually have a decent screening tool for psoriatic arthritis, and you have a treat to target in the PsO. And we incorporated this in Mount Sinai through the EPIC medical record. And this is a patient who on the portal, or I don't know where, but let's say for sake of argument, on the portal, they did their PES. It was greater than 3, and their PsO score was greater than 4. When the doctor opens up the chart for the first time, they will see this message. And it's the top yellow says your patient's PES score of 3 or more indicates that the patient could have psoriatic arthritis. If you're uncomfortable treating psoriatic arthritis, please click this button to access a rheumatology consult. Then the next message below says, if the patient's PsO is greater than 4, it suggests that the psoriatic arthritis symptoms may not be well controlled. Click here for a referral to rheumatology. And it also lists all of the FDA-approved drugs for psoriatic arthritis. And we have presented data, which I'm not going to present here, most recently at the AAD meeting, that shows that this strategy does work, and 3/4 of patients actually in our dermatology practice are in target as measured by the PsO score. I'll talk a little bit about a differential diagnosis. Again, look here, we have some of my 2 favorite psoriatic arthritis-ologists who authored this handout, and I think it's very useful. So, differential diagnosis. So psoriatic arthritis is typically asymmetric. I will point out that, especially in women, 20% of those cases can have a bilateral symmetric polyarthritis that looks just like rheumatoid arthritis, except you see skin and nail changes. And it is having DIP joint involvement, distal interphalangeal joint involvement. Sacroiliitis is present as opposed to ankylosing spondylitis. It's asymmetric generally. It is an inflammatory arthritis, so stiffness upon rest and improvement with activity is present. Enthesitis is present. Rheumatoid factor generally is negative. For those with axial disease, they can be HLA-B27 positive, but not nearly as in high percentage as ankylosing spondylitis. There are typical radiographic changes. You can have both erosions and excess bone formation in the same unit, like the hand, and that's different from anything else. And in its extreme, you can see pencil and cup deformities and asymmetric syndesmophytes. For rheumatoid arthritis, it's almost always symmetric. DIP joint involvement is not common. Sacroiliitis is not common. Stiffness on immobility is common. This rheumatoid arthritis does affect women far more than men. And this is not a typical enthesial disease. Rheumatoid factor is present. And what you see on x-rays predominantly is periarticular osteopenia and erosions. What about osteoarthritis? Yes, you can have peripheral disease. It tends to be asymmetric. You have DIP joint involvement, and as you know, it's called Heberden's nose. This is generally not an inflammatory arthritis. However, it can present that way, and this is a rheumatologist patient case. This is not one that dermatologists can deal with. Here, you really do need x-rays and other things. Sacroiliitis is not common. Stiffness improves with activity. Enthesitis, not really. Rheumatoid factor, no more than controls of the same age. And here you see osteophytes, and you can see erosions, but it does not look like rheumatoid arthritis. I'm not going to go into ankylosing spondylitis, which often does not have skin involvement. So let's go into comorbidities. You've heard about this from the other segments, so I will do this briefly. Psoriatic arthritis, the most common comorbidities in 30 to 40% of patients. A metabolic syndrome and cardiovascular disease is a risk factor that is, of course, is more with heavier patients, but it's an independent risk factor shown by Joel Gelfand. Multiple sclerosis is said to be a comorbid factor, but frankly, it is, in my experience, I don't come across it often at all. Malignancy certainly as a result of treatments, for instance, skin cancers with PUVA or with cyclosporin, etc., can be increased in psoriasis. Depression is definitely common in patients with psoriasis. Congestive heart failure, atherosclerotic cardiovascular disease is increased in psoriasis. There is both a genetic and epidemiologic association between psoriasis and inflammatory bowel disease, and obesity is present. In psoriatic arthritis, it's probably even worse. One thing you see more in psoriatic arthritis and psoriasis is uveitis. It's in about 2% of patients, and it's quite unusual in pure psoriasis. But you need to be aware if patients complain of symptoms. Inflammatory bowel disease, we talked about a relative risk of over 6-fold. Clearly, permanent X-ray findings are present. Also increased cardiovascular disease, metabolic disease, depression. And Philip has been very much involved with this, but high degree of fibromyalgia, which does make diagnosis of enthesitis extremely difficult and to follow clinically. And maybe I will ask him to comment about fibromyalgia in psoriatic arthritis and other inflammatory arthritides.
Thanks, Alice, for asking about fibromyalgia. It is, I think, an important topic for dermatologists. They may not know much about it. Rheumatologists certainly do. It's a condition in which a patient experiences amplified pain, fatigue, sleep disturbance, and possibly various psycho-emotional problems, including depression. And it really is a central nervous system phenomenon where there is an increased activity of nociceptive neuropeptides and a decreased activity of some of the ameliorative neuropeptides like norepinephrine and serotonin. We've learned a lot about it from a biological point of view over the last couple of decades. It definitely is an accompanying condition for many of our rheumatic diseases, with figures ranging from 10% on the low end to 40 or even 50% on the high end, depending on the cohort. And because this condition may not it shouldn't actually respond to immune moderation, it may need additional types of therapeutic approaches. And as you mentioned, Alice, it can confound our ability to accurately assess whether the patient has gotten into a state of low disease activity or remission, and so may mislead us. And we may end up cycling through various treatments only to find that we're chasing fibro instead of psoriatic arthritis.
So, choice of drugs, okay? This is courtesy of Joe Marola. Non-steroidals are actually decent for peripheral arthritis and also for axial disease. It was interesting on the GRAPPA presentation that Philip made that non-steroidals didn't have much of a safety signal. However, gastrointestinal bleeding and intolerance is not unheard of by any means, and you have to be careful about using non-steroidals with methotrexate and other drugs that are excreted renally. So they're not totally benign drugs. Intra-articular steroids are okay. I think we use much less of them with the treatments we have. Topicals do nothing for the joints. Ultraviolet therapy does nothing for the joints. Conventional DMARDs, and here I'm focusing on methotrexate more than anything else. Good for peripheral arthritis, good for skin and nail disease, but not outstanding. Don't use it in axial disease, it doesn't work. Not terrific for IBD. I'm not an ophthalmologist. It gets a check mark for uveitis, but it wouldn't be my first choice. Apremilast is decent for peripheral arthritis and skin and nail disease. Would not use it in axial disease. Has some activity in dactylitis, enthesitis. I know they did in inflammatory bowel disease. They didn't pursue it. I asked them, does it make it worse? And they said no, but of course, if the drug causes diarrhea, it's hard to distinguish from IBD. Uveitis, I don't have a clue. Anti-TNFs, they clearly have been the foundation and still remain, in a certain sense, the drugs to beat in pure joint disease. They work for peripheral arthritis. They're pretty good, especially infliximab for skin and nail disease. Axial disease, they're good. Dactylitis, enthesitis, inflammatory bowel disease. The adalimumab has an indication for uveitis. So the anti-IL-12/23 ustekinumab has approval for peripheral arthritis. It works quite well in skin and nail disease. Don't use it in axial disease. Doesn't work. It works in dactylitis. Enthesitis works well in IBD with a different dose and an IV load. And it's, for instance, a good drug to use for somebody who has TNF blocker-induced psoriasis and whether they do or don't have inflammatory bowel disease. Uveitis, I don't know. For the pure IL-23 blockers, they are approved for for controlling signs and symptoms of peripheral arthritis. None has a inhibition of radiographic progression yet. They work very well in the skin, except risankizumab failed in ankylosing spondylitis. Guselkumab has some studies pending in axial PsA. We'll find out. Dactylitis, enthesitis, it works for IBD. Excellent choice. Again, if you have a patient with psoriasis, psoriatic arthritis, and IBD, great choice. I don't know if IL-23 blockers work in uveitis. IL-17 blockers work very well in peripheral arthritis. There are a number of them that inhibit radiographic progression. They work very well in skin disease. They're fast. Also, they work in axial disease. Secukinumab has a dedicated study in psoriatic axial arthritis that works. The others get a halo by their approval in ankylosing spondylitis. They work in dactylitis and enthesitis. Do not use it in a patient with IBD, except in unusual circumstances. I'm not saying it's an absolute contraindication. Uveitis, I know that studies done to date with psoriatic arthritis and ankylosing spondylitis, you do not see an increase of uveitis. So I think that fact needs to be publicized more. JAK inhibitors we have in psoriatic arthritis. Upadacitinib also has an inhibition of radiographic progression in there. None of the JAK inhibitors to date have an approval in psoriasis. They work fairly well in psoriasis. Axial disease, they do by way of ankylosing spondylitis, dactylitis, enthesitis. They do work in inflammatory bowel disease. I don't know about uveitis. And finally, TYK2 inhibitor, we have only one now. They work in peripheral arthritis signs and symptoms to date, and skin and nail disease. And here's the usual multidisciplinary management of comorbidities slide. I have to admit, even though this would be the ideal way to do things, it's a bit aspirational to think how long it would take for a patient to see all these specialists in it, and you certainly won't see them in a timely situation. So I point to the fact that I still think the primary doctors for psoriasis and psoriatic arthritis are the rheumatologist and the dermatologist, and maybe the primary care doctors for managing the many of the comorbidities. So we would love to have all of this. I'm not saying not to, but at the same point, I think some of these like a hepatologist will call on when we need it. But to expect that all of these specialists will be taking care of all of our patients, I think is aspirational. But I do think the dermatologist and the rheumatologist run the show, and it is their responsibility to take care of the patient. And with that, I'll end. Your patients will thank you. Thank you again for joining us for this segment on early diagnosing and screening and managing comorbidities for psoriasis and psoriatic arthritis. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access supplemental slides, as well as other topic segments and case scenarios. Thank you.